Hello and welcome to today's episode of the Pediatric Consult. I'm Dr. Jill Schaffeld, your host for today, and I'm very excited to talk to today's guest, Dr. Bob DeFoor from the Urology Division here at Cincinnati Children's. Today's discussion is a consult on prenatal hydronephrosis. So let's go ahead and start by learning a little bit about Dr. DeFoor. So if you could share a few sentences just about your background, maybe how long you've been practicing, how long you've been at Cincinnati Children's, maybe even share some special interests with us.
Well, thank you. Thanks for having me. This is quite the treat. I have been on staff here at Cincinnati Children's for 22 years. I came in 2001 and did my fellowship, and the plan was to go back to the South where our family is from, but then the job here was so much better, and here we are. We've raised 3 children, and it's been a fantastic career so far, so we've been very happy. But yeah, I've been a urologist here for many years. I'm the fellowship chair for our training program. I also do a lot of clinical research and run our kidney stone center and just do a lot of bread and butter pediatric urology.
Wonderful. So I'm excited we can kind of delve right in. Our conversation today, as I mentioned, is on prenatal hydronephrosis, which I feel as a general pediatrician seems to be something that just over the years we see more and more on ultrasounds. You know, many of these prenatal ultrasounds are, just a normal anatomy scan at 20 weeks, but then oftentimes if there's anything that's concerning, there's multiple ultrasounds that are done. So, I was just interested if you could share with our audience and your experience and with your vast knowledge of the condition, just a quick overview, kind of data and incidents. I know I've, in preparing for this, looked a little bit anywhere from, I find, like 1% to 5% of prenatal ultrasounds that some bit of hydronephrosis is identified. So just curious if you could kind of give a overview and incidents, any tips for kind of when we might see this.
Yeah, so as you mentioned, this is one of the more common findings on their anatomy screen that's usually done, sort of mid-second trimester, and the term hydronephrosis just kind of refers to sort of dilation of the urinary tract, most likely in the kidney. And so as one of the more common findings, and as you mentioned, it's becoming more prevalent to kind of diagnose and find this. And we're sort of blessed in this community to have a high sort of prevalence of maternal ultrasounds. So more and more of these children are found sort of incidentally, whereas maybe a generation or two ago or in communities where there's not as, widespread maternal ultrasound, maybe the children came in later with more advanced conditions or came in symptomatic or with urinary tract infections. So hydronephrosis now most commonly is found on the prenatal ultrasound. And as you mentioned, about 1 in 100 live births have some sort of hydronephrosis. It sort of varies from the majority or sort of mild, self-limiting, not of much clinical significance, to very severe cases of bladder outlet obstruction that can lead to kidney damage, kidney failure, even the need for end-stage renal disease, renal replacement therapy. So it can kind of vary in spectrum, but the majority tend to be more on the benign side, yes.
Great. I also, in kind of prepping and thinking about this podcast, I came across something that mentioned a male predominance. Is that something you're familiar with? I will say my initial thought was, oh, wow, I'm not sure I would have guessed a male predominance with this.
That does seem to be the case for most of the, definitely the more significant pathologies, such as a ureteropelvic junction obstruction. And obviously, a posterior valve would be only in boys, but even in children who have some sort of bladder outlet obstruction, it's almost always males. Very, very uncommonly females. Sometimes with cloacal malformations or cloacal exstrophy or some other severe pelvic anomalies, they'll have some sort of bladder outlet obstruction. But yes, more likely in boys for most of these conditions. Yes,
which makes sense as you go through that. But I think once we get out in clinical practice and we're thinking about just UTIs in general, we're definitely thinking more of a female predominance. So
right,
I think that's an interesting tidbit, and it makes perfect sense. But for us to remember as general pediatricians that, your more severe cases will likely be in males, so just to be on more high alert for that. So Curious if there's any findings, and this can be prenatally, or even we can delve into a little postnatal on ultrasound follow-up. But are there any specific things? And part of it is just going to be as we begin to discuss the amount, whether it's mild, moderate, or severe hydronephrosis that we're seeing. But anything that would help us differentiate on a radiology report, reading an ultrasound as a general pediatrician, a more benign finding to something more serious?
Yeah, that's a great question. And so the sort of the risk stratification, I think, is what we're kind of deciding and what to do. And a lot of times these ultrasounds are done by the obstetrician. They may not sort of print out or upload the photos. They may not have records that are immediately available to you when you're rounding in the nursery, especially on a weekend. And so sometimes there's just this generic prenatal hydronephrosis, and we don't really know, how severe, if it was one side, both sides. Often the family may not have a full understanding of what the findings were. But if you're sort of fortunate enough to have like a written report or some sort of documentation from the prenatal visit, a lot of times they'll measure what's called the anterior posterior diameter, or the AP diameter. And that's basically the renal pelvis, which is the central collecting system part of the kidney, and sort of how spread apart it is. And so normally it's around 4 millimeters or less. Sort of the magic number, just to keep in your mind, is probably 10 millimeters. So if it's less than 10 millimeters, there's probably very low risk of some sort of obstructive uropathy going on. Could it be something like reflux or something else potentially? If it's over 10 millimeters, and especially if it's over 20 millimeters, then there's a high likelihood of some sort of surgical issue. So I'd say if you just have to remember one number, I would just say 10 millimeters. And if you're fortunate enough to have that information, if there's a history of hydronephrosis prenatally and they kind of mention that it's over 10 millimeters, then that would probably be more significant and necessitate a workup postnatally, yes.
Yeah, great.
Yeah.
Are those numbers, does that 10 correlate to what we would call moderate, and then the 20 severe? Is that kind of how it stratifies?
Yeah, and so there's definitely different sort of grading systems, especially postnatally, and some of them are very detailed and probably more for research, or for specialty kind of discussions. But in our hospital, the radiologists basically grade the hydronephrosis mild, moderate, or severe. And so that, you're exactly right. So 10 millimeters would probably be moderate, and then 20 would be severe. Yeah.
And I love that you touched on a very real life scenario, because I feel like the majority of the time we don't have a written report. Oftentimes in the newborn nursery, like you said, it is the family just mentioning it, or even at that first newborn visit in the office, we have all the labor and delivery notes, and maybe there's a mention of, but there's not an attached radiology ultrasound report.
Right.
So just curious, if we were rounding, kind of going with your scenario, on a newborn in the nursery, and parents say, there's something going on with the kidneys, they told us, and what's the best way to handle that scenario? How high, how, I guess, on how high of alert, I guess is how I want to say it, do we need to be? And is it something, if the baby's, otherwise looking well and growing well, do we say, hey, this can be a follow-up as an outpatient? Or do we say, we don't know what's going on here, and we have to be a little more conservative? What are your thoughts on that scenario?
Yeah, so, and obviously a lot of it has to do with, how comfortable you feel the family is going to follow up, and their postnatal sort of ability to come to office appointments and things like that. But I would say if you have very little information and you just have this generic sort of diagnosis of prenatal hydronephrosis, if it's a female, which would sort of increase the risk of getting a urinary tract infection and possibly sepsis, and you have no information, then that would be one that I would probably be more likely to do some sort of workup in the first week or two of life, possibly, with an ultrasound. We try to avoid ultrasounds in an otherwise stable a newborn infant in the first day or two of life, because as you all know much better than me, they're a little physiologically volume depleted. And so the ultrasound is very sensitive to the hydration status and can kind of undercall any dilation. Now, if it's bilateral in a boy, particularly if there was any concern for the amniotic fluid level prenatally, that would probably necessitate an in-hospital ultrasound and possibly referral if you had some concern about bladder outlet obstruction. But back to your point, if the baby seems well, they're voiding, there's no sort of physical exam abnormalities, maybe it's a circumcised male, the risk of infection would be very low. So in that setting, I would probably just educate the parents on what to look for, as far as fevers and things like that, and then have an ultrasound done, within a week or two after birth. And if there's any abnormalities, then sort of a subspecialty referral might be appropriate.
Absolutely.
Yeah.
And going back to the case for a female, maybe a little more likely, a little more conservative to do an earlier workup. Would you recommend, or at what point do you recommend antibiotic prophylaxis?
Yeah.
Leaving the hospital or even at that first visit?
Yeah, that's a great question.
Physician's office?
I tend to be very sort of conservative on using antibiotic prophylaxis in general, but if I am very uncertain and it's a female and I have a sense that there was enough significance to the hydronephrosis, then a low-dose antibiotic prophylaxis for a couple weeks till you can get an ultrasound is probably very low morbidity. And we usually use amoxicillin, 12.5 milligrams per kilogram once a day, which ends up being like less than a milliliter, basically just a drop in their mouth. So, whether there's great evidence for that is probably debatable, but I think if you're sort of concerned that this might be something more significant than and your sort of risk stratification in your mind is kind of raising a little bit of concern, then there's very low morbidity of that,
Yeah, perfect.
But again, if the baby's healthy and it's very mild condition, then I typically, don't do antibiotic prophylaxis. Yeah.
Yep, that makes sense. So I also just kind of looking, and hopefully you can share a little of your knowledge with us about this, is, what I had seen was of the percentage of prenatal hydronephrosis that's identified, that those that end up with any kind of postnatal pathology, that if they were graded prenatally as mild, that it's only about 12%, moderate, 45% of those would have some sort of postnatal pathology, and then 88% for severe. So, that's good to know, too, knowing if you do have that report and you can read that the hydronephrosis was on the mild side, that you can be rest assured that the majority of those will not have any significant postnatal pathology.
Yeah, and after 20 years of doing this and realizing that you don't have to sort of work every child up to the hilt, for all these conditions, I've seen lots of children with even moderate and severe hydronephrosis resolve over time.
Now I feel like, and now I'm going to ask you the tough questions, because I feel like there's probably a little bit of, all depends on the circumstances. But for me as a general pediatrician, when I have a newborn that comes in for their first newborn visit to the office, and I do have all this information in front of me, let's just go with the scenario that this baby I'm seeing has just mild hydronephrosis, one-sided, bilateral, growing well, doing well, no fevers, no concerns, feeding well, all the things. So all the good, positive things on report from the parents. What is the best option for timing for the first follow-up ultrasound, say, in the case of just mild hydronephrosis?
And you've already made the decision to do a follow-up ultrasound, then I would say 2 weeks would be fine.
Okay.
Yeah.
Well, so let's go back then, because I love you said that. I've already made the decision to do it. Do we not have to do it?
Yeah.
If we have the information that it's just mild and the baby's otherwise doing well, can you just watch them with no ultrasound at all?
Yeah. In fact, if it's like 7 to 10 millimeters and you have that information and, there's no other concerning findings like the ureter was dilated, the bladder was distended, or anything weird with the amniotic fluid levels, then you could probably just do clinical observation only. And I tell parents and pediatricians who call me, just have an index of suspicion to check a urine culture, because as you know, if a boy comes in that's circumcised and has a fever, UTI would probably be at the very bottom of your list of things. And as we've already said, there seems to be a male predominance in sort of more obstructive uropathies in boys. And so it's not the first thing you would think of, I would guess, if a boy comes in with a fever. So that would be really a very reasonable kind of management pathway, and avoid the ultrasound, avoid the consultation, and all that.
Wonderful.
Yeah.
I love hearing that, because I feel like in medicine we always want to tie things up. Well, there was this abnormality. We need to check it again. So it's great to hear from a specialist that's, got as much experience as you do and has done this for so long that it is completely reasonable to just watch those kids. So if we move up to 10 millimeters or more on the moderate side, timing, you said, in the first couple weeks as well. And then let's just say that ultrasound is stable and they still have moderate hydronephrosis, whether it be left, right, bilateral. What would be, without symptoms, the follow-up interval there? And is that also once we hit that moderate level? Because, in data I'm looking at, 45% or so have some sort of postnatal pathology. Is that, in your opinion, an immediate referral and ultrasound? Or
and I think it probably depends a little bit on your sort of risk aversion, and also sort of the and I tell parents this all the time, or pediatricians all the time, if the family's super anxious, then just send them over and we'll talk about it.
Absolutely.
We'll reassure them. But if the family seems okay with just kind of keeping an eye on it, I'd probably, if they were seeing me, I'd just do another ultrasound in 3 months, with no prophylaxis.
So at the 2 weeks, at the 3 month point.
Yeah.
So.
And then sometimes the question comes up, do we get a VCG? And I would say, as a blanket statement for pediatricians, feel free to punt that decision to the urologist.
Great.
Yeah. And for me, if it's moderate hydronephrosis, they're asymptomatic, there's no dilation of the ureter, there's no duplication of the kidney or scarring of the kidney or anything like that, nephropathy, then I probably would not do a VCG. Yeah. Especially in a circumcised boy, I would not. Yeah.
And then I think that, of course, once we hit that severe mark, they should be seeing you guys
then,
for sure. But then also that initial ultrasound, would you do that sooner or still at the 2 week point?
Still at the 2 week, yeah.
Okay.
Yeah.
Great.
Yeah. Especially, like we said before, if it's done too early, it can be not super helpful. Yeah.
Which makes sense.
Yeah.
So, great. Let's see.
And I would say in my 20-something years, I have not been sort of, quote, burned by that sort of pathway ever. Like a baby comes in at 7 days of life with sepsis. I've never seen that. Yeah. So
I think that's great. It is such an interesting thing to me, thinking over the course of my training, how much that I do feel like a lot of this has changed. So it's great to hear, and to hear some very concrete, this is what we can do. So, so you mentioned, 2 weeks, 3 months for these follow-up ultrasound, as long as things are going well. Do you follow, if they're moderate, do you follow those kids until it's completely resolved? Or let's say you go through the first year of life and they're just stable at moderate.
Yeah, those are tough decisions. And again, a lot of it depends on sort of the tension in the room sort of thing. But yeah, for me, if it's moderate at 3 months and they're asymptomatic, I might do another one at 6 months. I'll tell parents stable's good. If it's starting to get a little bit better, then I'll increase the interval, and maybe do one more at 6 months. And who knows how often they come back. I don't really track that, maybe they don't. But if it's severe, that, at the 2 week, then I might do it even sooner than the 3 month, maybe a month or something like that. So, but yeah, back to the sort of the mild to moderate, I think a less intense protocol is appropriate. Yes.
Great.
Yeah.
Any thought, or just if you could share with us, we touched on this with males, but some of the main reasons why we might see, like what type of anatomical abnormalities, kidney abnormalities, might we see that would cause prenatal hydronephrosis? So we mentioned posterior urethral valves, we mentioned a couple things, but just kind of going through to remind us as general pediatricians, what are the most common things that might cause clinically significant hydronephrosis?
So sort of most common to least common. The most common would be a ureteropelvic junction obstruction. That's where the renal pelvis is dilated and the ureter is normal, and so there's some sort of very short intrinsic, typically in obstruction or partial obstruction at the level of the kidney and the ureter. That would be sort of the most common. And again, there's still a good chance of that to resolve on its own. Sort of less common would be a ureterovesical junction obstruction where the ureter's dilated and the kidney's dilated. And so there's a partial obstruction at the level of the bladder where the ureter inserts into the bladder wall. And that actually has an excellent, prognosis for spontaneous resolution. And we use sort of the 1 centimeter diameter of the, again, 10 millimeters of the distal ureter as sort of the magic number. So, so again, 10 is sort of the magic number. If it's less than 10 millimeters distally, then there's a really good chance it'll go away. And that's, that patient would probably get a VCUG just to make sure that it's not reflux. But if the VCUG is negative, then we would even, tell the parents there's a very good chance that this will go away. Yeah.
I just wanted to also touch on, so not just those abnormalities, but, and I don't know if you have any specific info to share on this, but that I think it's always good to remember with certain genetic syndromes that, they would be more likely to have kidney problems, and maybe those, besides all the specifics we're talking about with mild, moderate, that if you have a child that also has a genetic syndrome and has some of these things identified on their prenatal ultrasound, that they may require more close follow-up just because they're more likely to have these other renal abnormalities as well. So any specific genetic syndromes that you feel like we should be on high alert for?
A lot of these would probably already get evaluated, but your Vater syndrome, your anorectal malformation, your cloaca, your neurogenic bladder, spina bifida, all those patients would potentially have some sort of kidney risk. But as far as sort of generic, or not generic, but just other sort of syndromic things that aren't anatomic, I'm not thinking of anything right off the top of my head. But
no, that's absolutely fine.
Yeah.
Any increased incidence with trisomy 21?
Well, not really. What we see in those children is sort of more bladder issues as they get older. They end up having really large bladders and sometimes have some difficulty emptying. Okay. But that's something that we see more in the teenage years.
And not necessarily.
Yeah, not necessarily as a baby.
Infancy, which is great info as well.
Yeah, unless they have a tethered spinal cord or some spinal abnormality. Yeah.
Okay.
Yeah.
So we had already touched on antibiotic prophylaxis. Any other times when that would be indicated? Anything else you can think of besides what we mentioned, which sounds like often just if we don't have info and we have, a high index of suspicion, or if we know that hydronephrosis, would you say if it's in the moderate category, we would start antibiotic prophylaxis, or not always?
Not always, yeah.
But severe for sure.
For severe, I think that's safest to do. And we might stop it at 2 weeks, or whenever we see them. But yeah, if the ureter's not dilated and it's moderate hydronephrosis, I think the risk is low of a UTI, and I would probably not do prophylaxis, yeah.
So really severe cases or moderate with some other abnormality like we talked about.
Yeah. Or if there's a concern for bladder outlet obstruction,
Which we're probably also at that point referring on to urology.
Right.
Also, just kind of thinking about our audience, I feel fairly comfortable with this, but are there any specific cases where the referral would go to nephrology and not urology?
That's a great question, and we would both be very happy to see these patients. And it's interesting, sometimes they get sent to nephrology, and I don't really understand why, and they'll kind of follow them, and then they'll refer to us if they think there's a surgical issue. But yeah, so nephrology does occasionally have patients come in to them primarily, and that's totally appropriate. And we share a clinic, as you may know, and so we do a lot of sort of off-the-cuff consultations, and let me run this by you, take a look at this ultrasound, and so we communicate with nephrology quite regularly, and so they would be very quick to send to us if they think it's a surgical thing. Yeah.
Great. Yeah. Just thinking along, because I feel like we've had a lot of wonderful information here. Any data to share with our audience in terms of, I know you had mentioned a couple times that even moderate prenatal hydronephrosis, VUR, UPJ, that those all actually, there's a pretty good amount of those that resolve. Do you have any data in terms of like percentages, or just to kind of give us a
I would say with the, I would say in general, there's a very high likelihood of spontaneous resolution for almost all of these conditions. And I have several sort of cases that I present to our fellows of severe hydronephrosis that resolved. I tell parents, if you wait long enough, a lot of these things get better on their own. And you mentioned reflux, and that kind of depends on the grade of the reflux, of course. And so
Sure.
if it's low grade and it's asymptomatic, we're a lot less aggressive, than we used to be. And when I first started training 25 years ago, I felt like I knew how to manage these conditions. Every patient got antibiotic prophylaxis. Every patient got a VCUG and a renal scan, and you worked everybody up to the hilt. And then after 20-something years, you realize there's a lot of normal studies and a lot of negative workups and a lot of kids who got catheters and IVs and a lot of repeated testing that may have not really benefited from that. So, I think that experience has allowed me to be sort of less dogmatic, than
Sure.
we were sort of 25 years ago. Like
Sure.
you mentioned, things have changed. And we're, probably picking up a lot of more, less clinically significant conditions also. Yeah.
And along those same lines, at what point do you decide as the urologist, okay, maybe timing in the child's life, maybe worsening of any of these conditions that we've discussed, that surgeries?
Yeah. 3 months that I did a pyeloplasty on last month. One was 4 kilos. And so, if it's and again, we see sort of the worst of the worst, like the most severe pathology. So our perspective's probably a little skewed where pediatricians see all these normal workups and all these kids who do fine, whereas we see the worst. But yeah, so if it's severe hydronephrosis in sort of a UPJ type configuration, then we'll do what's called a Lasix renal scan, which it would not be something you would probably want to do, from the pediatrician's office,
Sure.
Before referral or whatever. And, if that shows an obstruction and or sort of strain on the kidney, then we would proceed to an operation. Yeah. And so we have sort of specific criteria for surgery. And it kind of depends on, in an asymptomatic child, it depends on the drainage pattern and how well the kidney's working. So if the kidney's strained and not working well and draining very sluggishly, then that would probably lead to an operation, yeah.
Sure.
And so we would do that at whatever age. And even with the little babies, like the 4-kilogram baby, we did it laparoscopically using
Wow.
a surgical robot with sort of 3 8-millimeter incisions, and the baby went home the next morning and without any kind of drainage tubes or stents or catheters. And I just saw her yesterday, and she's doing fantastic. And
That's amazing.
sometimes the parents, they weren't symptomatic, but now they're feeding better and they seem happier.
Yes.
And, obviously in a baby, it's hard to tell what's going
Sure,
on with
those
them.
little
So, yeah.
things, but
Yeah.
that's great to hear.
Yeah.
I'm literally just being the general pediatrician across from you in awe right now is what I mean to say, trying to think of size of those little kidneys. So,
Yeah. Yeah.
pretty amazing for a 4-kilo baby.
Yeah,
So.
and in the old days, they'd have an incision, over their flank, and so even up to, let's see, we got our surgical robot in 2008. So up to 2008, we were doing open pyeloplasties, which was a flank incision, which is very painful and usually in the hospital with an epidural 2 or 3 days. So now they
Wow.
sometimes go home the same day.
Perfect.
Yeah.
So one last scenario that I realize I didn't touch much on is if we were thinking maybe a child we're seeing, it might be a little older, maybe not an infant, but that has some sort of obstruction, or maybe this was something that wasn't identified in the hospital and the child's done pretty well. What type of symptoms should we look for as pediatricians when parents come in saying, hey, my child's having these specific symptoms, and say, oh, this should really clue us in that we're looking at something more, renal-wise, or maybe some uncommon symptoms that we don't always associate with that you could share with us?
Yeah, great question. And so excluding the children who have like a febrile urinary tract infection or, some other reason to have a workup. So, the classic symptoms would be sort of flank pain, a palpable flank mass, blood in the urine, after some sort of minor injury. Sometimes we'll see a football player have some sort of minor hit in a practice or a game and pee blood for a day or so. And then sort of the most non-intuitive symptom that we see that can be related to the kidney is cyclical vomiting. And we actually did some research on this. We had maybe a dozen kids who presented with cyclical vomiting, and the sort of the latent time between the onset of symptoms and the correct diagnosis was sometimes up to 6 to 9 months. And then one patient was 2 years. And, they'd had all kinds of GI workup and like even a scope and all this kind of stuff. And then eventually it turned out to be, a UPJ obstruction. And again, it's not sort of intuitive why that would be the case. It's often the left kidney. Maybe it's near the stomach, I don't know, but if you've ever passed a kidney stone, it makes you want to throw up, so, and that's miserable. But yeah, so sometimes the parents will say, yeah, every 3 to 4 weeks they have like a stomach virus. And then that just seems a lot of stomach viruses, even for a child in daycare. So that would be one that in the back of your mind, if you have this kid that sort of seems to have that kind of pattern, I would probably do an ultrasound and just kind of make sure the kidney looks okay.
Sure.
Yeah.
That is great information. I love it. I love doing these because I learn so much, but that's definitely not something that's really on my radar that, cyclical vomiting, you immediately think stomach. So wonderful information to share with our audience, that to always have that, on the list as well. So, well, I have learned so much today, and I really appreciate you joining us. It's been great. This is, I think I shared with you before we started that I was excited to do this because I feel like this is such a pertinent topic for pediatricians, and so much has changed over the years. So hopefully this gives all of our audience some more guidance and just some more confidence. And we are absolutely lucky to have such an amazing urology presence at Cincinnati Children's, and we appreciate you being here today.
Thank you. And if I could just say one last thing, the e-consult feature through Epic is, I think, very helpful. So if you feel like you don't want to kind of wait on the phone to reach one of us, just send us an e-consult. If you include the name of the patient, what I typically do is actually go and look at the ultrasound myself. If there's a question, then I'll call or e-consult back to the provider. And we're always happy to get calls if you're rounding in the nursery and you're like, I really don't know what to do with this. I don't want to spend all day digging through some protocol algorithm online. Just give us a call. It's a very common question for us, very easy for us to kind of dispense, advice. And like I said, if they've had an ultrasound, I'll usually go look at it and then give you kind of a better opinion. So, but always feel free to reach out to us, anytime, day or night, if you have questions about this sort of thing.
Yeah, thank you very much. Well, again, we appreciate Dr. DeFoor being here today, and I want to mention to our audience that CME will be available at the end on the main page of this episode. So just go ahead and kind of click on that link, and those questions will be there. So we appreciate everyone listening. Thank you again, Dr. DeFoor.
You're very welcome. It's been a pleasure.